It's the Metro on WDET. I'm Robin Vincent. It's a medical mystery with destructive elements. Our cells divide and grow with unstoppable force. They seize surrounding tissue. They invade from within. That is how cancer works. In cases of younger people getting cancer, folks under the age of 50 have been growing. Someone born in 1990 is now 4 times more likely to get rectal cancer and 2 times more likely to get colon cancer than someone born in 1950. Why? And what is it like to be a doctor in Metro Detroit fielding these cases? Dr. Thomas Kelly is a gastroenterologist at the Karmanos Cancer Institute. He joins me now. Dr. Kelly, welcome to the Metro.
Hi, thanks for having me.
Okay, so to the best of your understanding, why are people under 50 more likely to get cancer today than in the early 90s?
That's a great question. The short answer is we don't know. We have some ideas based on some basic science work, some search of microbiology in cancer patients at young ages. And we have some ideas from inflammatory models in animals, but we don't actually know why humans are getting it at a younger age. They have recently lowered the screening age from 50 to 45 a few years ago, and that likely has helped a little bit, but more work needs to be done.
Okay, so there are a couple things at play here. You're saying that there are likely some environmental causes, that it could be the things that we're exposing ourselves to, but also it's that more folks are getting screened at a younger age, and so you're catching cancer earlier.
Yes, on multiple levels. It's too soon of a change to be genetic. It has to have an environmental influence. Whether it's something we're exposed to, a chemical, something we're eating differently, there's definitely changes. And we're seeing some interesting things with microbiology and also food science in that I think are fascinating and sort of relate to your last speaker.
Right. Glyphosate, our exposure to something that a lot of people are suing because of developing cancer from exposure to. We're going to get into that, into some of the potential reasons, which, again, I realize that you are a person of science and you're trying to be careful to not unequivocally say anything. But we're going to talk about some of the potential reasons that we're seeing this rise in cancer. But first, I want to ask you what it's like when folks speak about young people having cancer. They generally mean people under the age of 50. When you treat younger people with cancer, how old are they in general? And what has it been like for you to be working with younger people seeing this disease?
So as a gastroenterologist, my role is often in the initial stages of diagnosing colon cancer. So it is a tricky question for me to answer because I often am the person that's giving them the initial diagnosis and then sometimes managing a very complex endoscopic problem that develops later. But the younger ages has been shocking. Looking at literature, they're saying that this has been happening for at least 20 years. So I haven't personally noticed the change, but it is heartbreaking whenever a 42-year-old gets diagnosed with cancer, and the screening age starts at 45.
What are you saying to them? I mean, are you seeing patients even younger than that who you're diagnosing with cancer?
I have seen patients younger in the hospital, but and that's even more heartbreaking. And that's devastating when it occurs for everyone involved, including the physicians and staff. But when a younger person, say 42-year-old, is diagnosed with cancer, it's a big shock to everyone. And we start by telling them that they have options and getting them lined up for treatment and getting them lined up for further diagnostic testing. So it's great when they have a family that can come with them to the procedure so that if bad news were to occur, on the unlikely chance, that we can get them so they can retain the information that we talked to them about.
Doctor, when you're saying that it is shocking to see cancer in younger patients. Are you saying that it's shocking because you're not seeing it happen with great frequency? So when it's happening now, it still comes as a shock every time.
I think that's correct. The vast majority of cancer patients for colon cancer, at least, are older, and we still have a long ways to go on colon cancer screening. I think 60-some% of Americans are being screened for colon cancer. We could improve that closer to 100%. We could save many, many more lives. In terms of cost effectiveness, that would be the most bang for your buck. We have to use a separate graph system when talking about young people because the incidents are still so low. It is rising in the younger population, but the vast majority are older.
So you are very much in the camp of encouraging more screenings and potentially at an even earlier age than 45?
It's all about cost effectiveness. It's hard when you look at medicine. You can look at the individual level, or you can look at the population level, and sometimes those are different. At a population level, we have to think about cost. At an individual level, it's a little bit different, but we have to take each patient, each situation, and listen to the patient and go from there.
I have been observing some discussions among millennials who are saying, I want to be screened, but my insurance doesn't cover it until I turn 45. And so I am going to say that I have symptoms. I'm going to say that I have a history of cancer that is among a close family member. This, to me, paints a level of desperation among people right now, and also perhaps a problem with insurance and what gets covered when. I mean, what do you have to say about that?
So there's two types of colonoscopies. One is a screening colonoscopy. The other is a diagnostic colonoscopy. A screening colonoscopy is, by definition, an asymptomatic person who's getting checked for precancerous growth or early cancer. Ideally early cancer. It may be late cancer, but ideally early cancer. Diagnostic colonoscopy would be done for a symptom: bleeding, change in bowel habits, unintentional weight loss, iron deficiency, anemia. There's a list of indications for a diagnostic colonoscopy. So if someone has rectal bleeding in 2026 and they come to my office, they're likely going to be offered a colonoscopy. I don't want to encourage anyone to lie to their physician. I think that everyone should tell the truth to their doctor. 90% of the answers come from the patient. So if you listen to your patient, you'll get the answer.
I hear you on that. Of course. I mean, we want transparency between patients and physicians. But again, what is striking me about this is that there may be some really big problems in the system. If folks are feeling like, I think I should be able to get screened at an earlier age, but my insurance won't cover it.
That's a very tough question. I think big policy changes for our government could be considered, probably best on a separate discussion. But our healthcare system is in some ways broken, and it needs to be fixed. I don't know how to answer your question exactly.
That's fair. I think there are a lot of questions we pose on this show that don't necessarily have immediate answers. I do want to look at some new research that came out suggesting that the story of young people getting cancer might not be as bad as we thought a few years ago. The article in the JAMA Internal Medicine found that young people are about twice as likely to get cancer as in 1990, as we've discussed, but the number of aggressive cancer cases has not increased at the same rate, and the death rate for 8 cancers covered in the study remained flat over the last 35 years. So essentially, that means that these types of cancers that younger people are tending to develop are not as aggressive. Am I reading that right?
That's a great question. I'm not familiar with that study. I'll have to read it now. I think that cancer treatment has evolved a lot, even in my generation. What used to be considered a fatal diagnosis is turning into chronic diseases. Certain cancers outside of my area's expertise, like I see remarkable successes in lung cancer for those that respond to immunotherapy. They're turning into a chronic illness. even with disease that is spread to the brain. Now, not everyone responds to these drugs, but if we could find more drugs to turn more cancers into chronic diseases, that would be phenomenal.
It's the Metro on WDET. I'm Robin Vincent. My guest is Dr. Thomas Kelly, who works at the Karmanos Cancer Institute in Detroit. We're discussing why cancer is showing up in younger people and what can be done to prevent it. So, Doc, I want to connect something from earlier in the show, which you astutely mentioned as well. We spoke with Harvard historian of science Naomi Oreskes about Roundup, the weed killer, and growing research around glyphosate and cancer. Now, most of the lawsuits that people have filed from exposure to Roundup involve them developing non-Hodgkin lymphoma. But there's newer research specifically looking at the gut. So I'm just going to quickly summarize some of it. There was a National Cancer Institute study that linked glyphosate exposure to oxidative stress, and that's a marker associated with cancer development. There was a large county-level study published last year that found a significant association between glyphosate use and colon cancer rates across the country. There were a few more studies I found, but you're getting the picture here. I'm wondering if you've come across any of this research and what you make of it.
So I have to be careful. Glyphosate is something that I've been concerned about before it was listed as a 2015, I believe, international probable cause of cancer in one of the regulatory bodies for cancer centers. I think that it's a drug, a chemical, that not only kills herbs, but also kills bacteria, parasites, fungi. So initially I was concerned about soil. But if you think about our body, we have more bacteria in our body than we have human eukaryotic cells in our body. We don't know how that drug or chemical is affecting, and we don't know if the amounts we're getting in our food supply or home use. It's concerning. It's concerning when they put little flags in people's lawns saying, do not let children or dogs on this lawn after it's been sprayed with chemicals. I doubt they're spraying glyphosate because that would kill the grass, but they're spraying other things.
Could I ask you if you personally are trying to limit your own exposure?
So I don't spray my lawn with anything, and I pull my weeds by hand, which may make my neighbors upset. I'm sorry if that's the case, but I do limit exposure to many chemicals.
And then there's also something else that we're exposing ourselves to. We've all sort of become an experiment in this, and I'm talking about ultra-processed foods.
So processed foods are very interesting. When you think about cancer and inflammation, I also treat inflammatory diseases. They make animal models to try to replicate inflammatory diseases. And certain inflammatory diseases like ulcerative colitis drastically put you at rates for colon cancer. And the thought is an inflammation to cancer pathway. In a rat model that I went to a lecture a few years ago, they fed the rats, a knockout rat that's predisposed to this condition, 1% fat emulsifier chemical. And that's about the percentage that we get in the average American diet. And those rats develop significant inflammation. While it's not directly linked to cancer, in my mind, it's enough concern that I think we should be looking at processed foods in regards to inflammation. The gut is a delicate balance between bacteria, the lining cells, which eventually turn into precancerous or cancerous, and the immune system or the inflammatory response. So I think these are very interesting areas of research, and we should be careful with emulsifiers. One of the audience members stood up and asked, what about soy lecithin? Or I can't say that word right, but
lecithin.
I'm not sure.
Yeah.
But,
I don't know either.
But they said they see the same results, but I didn't see that publication, the follow-up publication. But if you look at your packaged food labels, it's always the last ingredient or so, second to last ingredient.
Yeah, and you're talking about something that thickens foods, and soy lecithin is found in, or lecithin, however we want to say it here, that's how it's spelled. It's found in yogurts, it's found in nut milks, it's found in a lot of different packaged foods. And also what this has me thinking about too is I've seen some discussion about how this is changing our gut flora when we're eating ultra-processed foods, or when we're eating different so-called natural sweeteners, even like stevia, which, for a long time, folks have believed and continue to believe that that is a natural no-calorie sweetener. But there is research showing that that can change your gut bacteria. And so I wonder then, for you as a gastroenterologist, that's a problem, right? If you are significantly disrupting the bacteria in your gut.
So it's tricky when patients ask questions about gut bacteria because we don't know sometimes if it's the chicken or the egg. We can check bacterial profiles of patients with early cancer and say this strain of E. coli is making a toxin which is likely causing the mutagenic effect, which is causing early colon cancer. We don't know if that's the chicken or the egg. Is that cancer somehow affecting the bacteria, or is the bacteria triggering cancer? Same thing with other microbiota profiles. We'll see in diseased patient versus a healthy patient and see a clear difference, but we're sort of just scratching the surface on our understanding. I advocate when patients ask about probiotics and other things they can do with their diet to eat like their great-grandfather or great-grandmother used to eat, and try to eat slow-cooked food from scratch. Try to avoid packaged food, processed foods. And it's hard in our modern lifestyle. I think that in terms of probiotics, if that's going to be your next question, I instead advocate for fermented foods. Kimchi, sauerkraut, whatever your traditional cultural fermented food is, embrace it.
There is one, it seems, within every culture, some type of fermented food. I think about in my family, it is Iraqi torshi, which is pickled vegetables, very like spicy cabbage and carrots, and I love it. I could put it on everything. What is the benefit of, so you're saying this is going to increase that good gut flora, and so you're among the camp of folks who say eat this every day?
I'm not sure about how often to eat it, but I think that it's good for you in terms of psychological, even if it's not proven in science yet. The way I look at probiotics that come in a capsule is it's got to be difficult to get past stomach acid. Stomach acid is extremely powerful. So if you can have the bacteria or the fungi hitch a ride on the natural food source for them, I think it has a better chance of actually getting to the colon.
I want to end on something, Doc, on how your work has changed because you see more patients and younger ages of people coming to you who have cancer. How is it different?
To me, I'm in the trenches. I don't notice the big difference, but it is more psychologically difficult, possibly on the providers when we see younger and younger people who are our ages getting cancer. But overall, it's still the elderly and the older population getting cancer. To me, I'm going to keep going no matter what. So I'm not sure if I can answer the question. But we have options on treating cancer. We have a great cancer center, Karmanos Cancer Institute right here. Great cancer surgeons. Great interventional radiologists that are ablating metastatic deposits. It's very impressive.
Dr. Thomas Kelly is a gastroenterologist at the Karmanos Cancer Institute. Doc, thanks for joining me on the Metro.
Thanks.
It's the Metro on WDET. I'm Robin Vincent. Coming up, the Trump administration recently decided not to regulate pollution. What does that mean for Michigan? We'll find out. That's next on the Metro. Stay with us.